Hi, everybody. My name is Jacob Pendergrast. I'm one of the Associate Medical Directors at the Blood Bank at the University Health Network in Toronto. And I'll be talking about how Ontario's first recommendations for massive hemorrhage protocol can be applied at smaller hospitals. So one of the challenges when we developed this protocol is we really only wanted there to be one protocol to be used throughout the province of Ontario. But at the same time, that protocol has to work both at a large urban hospital that has all sorts of resources and staffing available to it, and even the smallest hospital that may be limited in terms of inventory and staffing and is remote from sites that can provide definitive treatment. So there are a variety of ways that the massive hemorrhage protocol can be interpreted and modified and implemented at your local site if you are at a small or remote hospital, so that it will serve its main purpose. So I'm going to go through a series of recommendations that were within the massive hemorrhage protocol that was developed for all of Ontario, with the understanding that most hospitals in Ontario are relatively limited in terms of the blood products that they can provide. So this is a survey done a few years ago now in Ontario, but I suspect that the numbers quoted here are fairly consistent still. That way, they found back in 2007 that only 22% of hospitals in Ontario stocked platelets, only half stocked cryoprecipitate, 70% said it would take more than an hour to order additional products from CVS, and 22% said it would take more than 6 hours. So given all this, many hospitals didn't even have a massive hemorrhage protocol because they said there's really no point. We cannot provide enough blood products to treat the loss of an entire blood volume, which is typically how massive hemorrhage is defined. Nonetheless, every hospital that has a blood bank needs to have a massive hemorrhage protocol, if only to define how to use the limited blood products that you have and how to maximize hemostasis while you make arrangements to transfer your patient out. So again, all hospitals, and this is the first recommendation, shall have a protocol to guide the management of a massively bleeding patient. No matter how small, you have to have some sort of protocol. Even if you are working in a setting where you are seeing patients outside of a hospital, you need to have some sort of process in place to deal with a patient who suddenly develops massive blood loss. And this might occur in an ambulatory clinic. This might happen at a nursing station, a dialysis facility, even in a long-term care setting. A patient may suddenly experience massive blood loss. And there needs to be some kind of protocol for how to deal with that situation, even if you can't actually transfuse them on site. And generally speaking, that protocol is going to focus on rapidly transporting patients to somewhere where the massive hemorrhage can be dealt with more definitively. But there may be things that you can do to stabilize that patient while you are getting ready to ship them out. And again, that needs to be part of your massive hemorrhage protocol as well, even in these non-hospital settings. When you're dealing with trauma, it's important to note that in Ontario, the lead trauma hospitals are generally located in Southern Ontario. There's one in Sudbury as well. And certainly that is where you want your patient to be taken if they've experienced trauma. However, if it's going to be more than a 30-minute drive to get your patient to a lead trauma hospital, and a land ambulance arrives on scene, say before a helicopter or a fixed wing transportation does, then the policy is that that ambulance has to take your patient to the nearest emergency room, whatever is closest. Even if that's a very small hospital, that may be where the patient is brought. And so every hospital, again, is going to need to be prepared to manage these patients, even if they're only going to be with you temporarily while you await evacuation somewhere else. The third recommendation in the protocol is that it shall incorporate the principles of damage control resuscitation, specifically given highest priority to treating the source of hemorrhage. And again, there's another talk during the symposium on the details of damage control resuscitation. But it's important to be aware that there are probably a limited number of places in Ontario that can provide that definitive source control. And I'll use the example of vascular emergencies, which we know actually on a per capita basis are more common in rural than in urban areas. This is probably a reflection of the type of industry that occurs in rural areas, where there's more likely to be work-related accidents, for example, or even recreational activities, which might be more likely to result in an injury in rural areas. So again, the likelihood of encountering a patient with a vascular trauma on a per capita basis is actually higher in rural areas than in urban areas. And nonetheless, only 16% of hospitals have the capacity to actually treat vascular emergencies definitively. So this means that every hospital is going to need to have some sort of protocol for dealing with vascular trauma, at least on a damage control resuscitation perspective. That might be something as simple as a tourniquet applied properly. And again, that's going to be something that you'll need to make sure that everybody is adequately trained to apply. But there may be other types of damage control resuscitation involving tamponade of esophageal varices, for example, or uterine tamponade with balloon. Again, just to sort of try to get the basic hemostatic control in place while you wait for transport to another site where they can do definitive management. So again, that's going to be a very important part of your protocol, is getting that sort of emergency short-term hemostatic control. Fourth recommendation is that the protocol shall consider the available resources at the institution. Obviously, this is a big one when you're working at a small hospital, because a small hospital is going to be limited in a number of ways. It's going to be limited in terms of staffing. It's going to be limited in terms of certainly the available blood components that are on site. There will be fewer laboratory tests available on site, and you may have to wait a little longer for them in some cases, because the same person doing those tests is the person preparing your blood products. Your ability to provide definitive control of hemorrhage obviously is going to be limited if you don't have surgical specialties on sites to deal with, again, vascular emergencies is one example, but not all sites are going to have therapeutic endoscopy to deal with GI bleeds. So given this, there are a variety of modifications that you may need to make to your massive hemorrhage protocol if you are working in one of these more limited resourced areas. Things you could do, for example, would be having very clear criteria for when to initiate patient transfer so that you're not waiting too late. Making sure that you have pre-labeled uncross-matched red cell units good to go so that you can free up some time for the laboratory technologists to work on doing other things. Having pre-prepared sample collection kits with requisitions already filled in so that, again, you can get samples drawn and sent off quickly. Having simplified tranexamic acid dosing protocols, and I think there's going to be another talk on that topic later today. Having substitution of plasma derivatives for frozen plasma products if you don't have frozen plasma products or only a limited number on site, and we'll talk about that in a bit more detail later. And then whenever possible, using point of care technology, again, just to take some of the pressure off the blood bank where you may only have one technologist trying to do everything. Cross-training individuals at the clinical side will also be important. Even if you have clinical staff who are not trained in providing emergency treatment for massively bleeding patients, being able to call people in who can help with things like initiating patient evacuation, for example, running products and patient samples to and from the lab. Again, you want as many people to be able to help as possible, even if those are people who don't normally work in an emergency or critical care setting. The 10th recommendation is that the transport service should be promptly notified if the decision is made to transfer the patient to another hospital for definitive hemorrhage control. And if required, the patient should be transferred as soon as and as safely as possible by appropriate staff and transfer resources to an institution where definitive hemorrhage control can be performed. This is going to be the subject of another talk, and the details of how and who to do this for will be addressed there. But in general, what you need to consider here is that you may need to initiate patient transport even before massive hemorrhage has actually occurred, if you think that the patient is at high risk of developing massive hemorrhage. So for example, WHO grade 3 bleeding is not massive blood loss, but anyone who's grade 3 could become grade 4, for example. Patients who are at high risk of postpartum hemorrhage, because they have multiple pregnancies, because they have uterine atony, that sort of thing. Again, you might want to initiate transport early if they have a high trauma score, and certainly if there is early indication that a patient is hemorrhaging, even if you haven't confirmed it clinically or by imaging. For example, if they have a high shock index, all of these might be indicators that you need to initiate transport of your patient. Now, if you can actually achieve hemostasis locally, then maybe you don't need to ship that patient out. But achieving hemostasis locally means more than simply providing source control. You also need to make sure that you can continue to transfuse your patient if that source control fails. And you also need to make sure that you can provide some sort of monitoring of their hemostatic capacity. Can you actually see what their platelet count is? Can you do coagulation testing? You really need all three of these things to achieve hemostasis for a patient who is massively bleeding. And so if you don't have all three of these things, and your patient is bleeding or is at high risk of massive bleeding, then that should really be the point at which you are initiating transport, because it will take some time for your transportation to arrive. And you don't want to be waiting too late to get that transportation started. Okay. 14th recommendation, the protocol should specify how the lead clinician at the bedside is designated. In larger hospitals, this is usually fairly obvious. It's the trauma team leader, or it's the surgeon or the anesthetist, or the attending critical care physician, wherever the patient happens to be when the massive bleeding develops. That person does need to be named, but usually it's fairly clear who the lead will be depending on the setting. But in a small or remote hospital, you may not have any physician at all on site when a patient begins to experience massive blood loss. And so the protocol should acknowledge that fact, and rather than wait for a physician to arrive, whoever is available who could serve as the team leader should be named as such and trained and prepared to serve in that role. That might be a nurse practitioner. It might be a midwife, depending on where the patient is. And again, if you look at where the nurse practitioner-led clinics are, many of them are in urban areas, but certainly there are some that are farther north and in more remote areas. And nursing stations, you may be even further away and more remote. If you look at where the midwifery clinics are in Ontario, again, a lot of them are in the more populated urban areas, but some of them are quite remote. But regardless, whether you have an urban or a rural nurse practitioner or midwife-led clinic, there may not be a physician on site. And again, whoever is there needs to be prepared to step up and serve as the team leader, at least for the initial phase of management. The 34th recommendation is that the initial management of the rapidly bleeding patient that precludes the use of laboratory-guided transfusion should begin with immediate red cell transfusion and then transfusions at an RBC to plasma ratio of 2:1. And so the recommended boxes that would be issued would be box 1 having 4 units of red cells, box 2 having red cells and plasma, box 3 having red cells, plasma, and fibrinogen replacement, and then ordering in platelets based on the platelet count. That's sort of the standard approach for most hospitals. But if you're in a small hospital or a remote hospital, you may not have any plasma in stock at all, or any cryoprecipitate, certainly not platelets. And so you may need to modify what goes into each box to reflect what your local inventory is. And so the simplified option for smaller organizations essentially means that instead of issuing plasma, you can substitute prothrombin complex concentrates combined with fibrinogen, which is a reasonable approximation of what is in plasma. Certainly, if you know that your fibrinogen level is greater than 1.5, you could probably just issue prothrombin complex concentrate alone. In terms of platelets, again, we know that most hospitals in Ontario don't stock platelets. And if you have a massively bleeding patient, probably it makes more sense to ship that patient out rather than ship platelets in, unless you can get the platelets to you faster than you can get transportation. And this is actually something that you should look into arranging for yourself, not by necessarily stocking platelets at all hospitals at all times, because that would probably be wasteful, but by coordinating your inventory with other nearby small hospitals. So for example, this is how the hospitals within the Timmins cluster share their red cells. There's a redistribution hub at Sensenbrenner Hospital that receives products from other hospitals. That whole hub, those hospitals have an arrangement whereby they will share their red cells with each other, where if a patient needs massive hemorrhage support at any one of those hospitals, they will all coordinate with each other to send the red cells where they need to go. And there's another hub at Timmins and District Hospital. Again, the same arrangement whereby near outdating red cells are sent into Timmins to avoid wastage. But again, all hospitals help everybody else within that second hub. With platelets, we have 1 dose of platelets kept at Timmins and District Hospital. But that platelet is available to anybody who needs it, who's in that Timmins cluster, with the exception of some more remote hospitals along Highway 11, where it may actually be faster to get a product from Winnipeg in some cases. But in any case, waiting for platelets to be shipped from Brampton or Ottawa way up north will be hours and hours and hours, whereas you can get access to at least 1 bag of platelets from a nearby hospital if you need to. Not to say that this is an alternative to shipping the patient out, but just to be aware of what is nearby and what you can get delivered to you, and you may need to make arrangements with the OPP, for example, in some cases, to help ship that product to you. 36 recommendations that fibrinogen concentrate can be used as a reasonable alternative to cryoprecipitate for fibrinogen replacement. This substitution is supported by a recently published randomized controlled trial where they looked at patients undergoing cardiac surgery and randomized them to either get fibrinogen concentrate or cryoprecipitate if they had developed hypofibrinogenemia or a high suspicion of hypofibrinogenemia. And the result of that trial was that there really was no difference in clinical outcomes. And this opened the door to simply using fibrinogen concentrate as a replacement for cryoprecipitate in all settings. And this is something which is now endorsed by the National Advisory Committee on Blood Products in Canada. And what this means is that many hospitals that did not traditionally have a fibrinogen source on hand, they didn't stock cryoprecipitate, they didn't stock plasma, could now justify stocking a fibrinogen concentrate instead. And there are a variety of advantages to stocking fibrinogen concentrates. They are not frozen, they don't need to have a freezer, they don't need to be thawed as a result, they don't need to be cooled. There's no compatibility testing required. And they're relatively fast to administer, either by mini bag or just by direct IV push. So really, every hospital that may need to support a massively bleeding patient, and in fact, that means every hospital should have some fibrinogen concentrate on hand. And similarly, should probably have some prothrombin complex concentrate on hand as well, both to serve as antidotes for anticoagulants that the patient might come in with, but also as an alternative to frozen products. The only caveat being that if you are going to start stocking prothrombin complex concentrates and fibrinogen concentrates, you should have some sort of arrangement to redistribute those products as they're nearing outdate so they don't get wasted. And there are, in fact, networks available to help with that. So that is the end of my presentation. In summary, the consideration for the massive hemorrhage protocol implementation in small sites should include having kits prepared in advance. That includes having red cells prepared to be issued in uncross-match status very quickly. How your protocol adapt to the possibility that there may not be an on-site physician at time of patient presentation. There should be an emphasis on damage control resuscitation. Don't try to do everything, but what you can do, make sure everyone is trained to do that properly. Use derivatives instead of frozen products if you need to. Have very well thought out policies and procedures for patient evacuation, and then consider initiating transfer even if the patient is at high risk of massive hemorrhage, given the fact that there may be a delay before that transportation can arrive. Okay, thanks very much.